pneumonia, right? It's an inflammation of the lung parenchyma caused by infectious agents. You see the etiology. So tell me a little bit about the differences between the community acquired and hospital. Like, what does it matter? What are they called? Like, why do we make the distinction between community and hospital?
Hospital acquired ones kind of is indicative of the quality of care.
That too, but mostly because it's worse. Hospital acquired is worse, is really why we want to make sure that you don't get it in the hospital. But I totally agree. It does show lack of care, or it's usually because of the nurse and how she's, so because you need to know that, you have to be more mindful about washing your hands, about changing your gloves, that kind of thing. Okay, but it's technically the same process that happens, but just a little more severe, right? Okay, so we have persons at risk. Who are at risk for pneumonia? Elderly people, immunocompromised. I heard that. Yes, crowded areas like where? Schools, shelters, hospitals. Mm-hmm. Oh, yes, a concert. Or camping, like me. Like, you hear me nasal? It's not pneumonia, but I was with 600 people over the weekend, and now I have the sniffles. Do the math. Yeah, so definitely that. Jails, right? So definitely those people. How would we notice it? What are the common manifestations? What would we see? Crackles when we listen. What else? Productive cough. Fever. Chills, shortness of breath. Okay. Yes. Infiltrates in chest x-rays. Let's go back really quick because I see there are a few things that I missed. Cigarette smokers. We didn't mention them, right? People with other diseases that affect lungs, like COPD. Okay. We mentioned immunocompromised, but one of the specific ones are AIDS, HIV patients, right? Let's mention that. Okay. So the pneumonia that they have is specified as pneumocystis carinii. I don't know how to say it properly, but that's the one. Okay, so we already mentioned a few of the other signs. How about cyanosis? We didn't mention that. Pallor. Okay. All right, so tachycardia too. No one mentioned that one. How about interventions? What will we do for a person with pneumonia? Antibiotics, yes, depending on if they're not allergic to that one, right? But yes, antibiotic, penicillin being one of them. What else could we do? Spirometer. Once it's starting to heal, or even before it gets the process, once they're able to breathe through into it, right? We want them to start exercising their lungs. Why are we doing that? Why are we exercising the lung? Yes, to make it work better, because they were doing shallow breaths. They weren't really breathing at their fullest, so the capacity was reduced. So now we want to stretch it out to get it back to its vital, to get the vital capacity back to its normal range, so that they can have less tiredness, less of the other problems, right? Shortness of breath, all of that. Okay. What else can we do for them? Fluids, yes, we want to get them fluid, right? Because we want to clear it out, wash it out, right? But especially if there's like thick mucus, and coughing, that kind of thing, we want to lubricate the throat, get it thinner so it can come up. What else? Yes, we could definitely do pneumococcal vaccines, right? Yeah, we want to do that. Droplet precaution, yes. We want to make sure that other people don't acquire it as well, right? No one mentioned cough suppressants because they have coughs, but the major one, oxygen, right? Not everyone. Like when I was, I don't know, maybe 10 years ago. I don't remember. It's been a while. But super cold in New York, super busy, nursing school, all that other stuff. I was doing some church activity too. Anyway, I got pneumonia, but it was walking pneumonia. I was all kind of like fatigued and coughing hard and all this stuff. But yeah, so we want to make sure that it's not everybody who needs oxygen, right? Because those who are agile, walking, they have pneumonia and everything is relatively okay. But those who are in bed, comatose almost, like just no energy, not being able to breathe, all of that, they're going to need oxygen. Okay. What would tell us that the person needs oxygen? What would the measurement be that would signal us? the O2 stats would be where? What range? 95 and below, right? And with COPD patients, would that be the same thing? No, because theirs would be a little lower, okay? They function at a little lower, okay? We're isolating them. Speaking about isolation, I forgot to mention, when we talk about tuberculosis, what kind of isolation? It is airborne. Now, how do we know? So we have positive airflow, negative airflow concept. Do you remember what that was? So an emergency room is positive airflow, and tuberculosis room is negative airflow. What does that mean?
Negative, you don't want bacteria leaving the room.
Yes, right? So the suction, so how will we know we put a piece of paper on the floor? If it sucks it back into the room, it's negative airflow. It's sucking it in so that the bad stuff stays in the room. But positive airflow, the emergency room, not emergency room, the surgical room, wherever they do the surgeries. Can't even think about it. Say it again. The OR, thank you very much. The OR should be sterile, should be clean. So we know it's clean. We know every air in there is very good air. So we want to push that out and not pull anything in. So if we put the piece of paper outside the door, it's going to blow it away, right? That's important for us to remember, okay? All right, let's see, what else could we talk about? So some key points. So we mentioned the penicillin. That was a key point. It remains a drug of choice. We talk about antibiotics. What about the antibiotics? We mentioned this already. What's important to tell our patients about antibiotics? Keep taking it even if you feel better, right? Take the full course. 7 days, 7 days, 14 days, 14 days. Don't stop it. Okay? What else? Let's see. Anything else? Cigarette smoking, stop. Manifestation. I mean, if you can. Stop it. Okay. And then there's a latent stage. The notion, remember when we are taking these exams, sometimes the time matters, right? So if they say, oh, patient comes in, you come in the room and early signs of blah, blah, blah. So you need to know what that is, right? So early signs of respiratory problems are usually what? What's an early sign? Fatigued, yeah. Restlessness, right? More so restlessness, more than fatigue. What's a late sign? The cyanosis, right? Okay. All right. We mentioned, interventions. We said to stop smoking. What else did we say? We said isolation room, encourage them to cough. We're doing the Hoff coughing, training them how to cough, turning and positioning, right? Remember we said pneumonia, the fluid is in there. And so if they lay down, it's flat. So the, what is it called? The surface area is covered. But if they are up, it's like less surface area is covered with fluid. So we want them to sit up. They would prefer that too. We give them oxygen. We mentioned that. Teaching them to exercise, walk around, movement. Movement helps with circulation. Circulation helps with healing. No one mentioned food. Make sure you eat well. You did mention fluids though. So definitely want to eat well. What else? Yeah. Okay, moving on. Okay, let's talk about cancer of the lungs. So if you have cancer of the lungs, that is a primary or secondary. So it could be metastatic from another space, or it can be in situ. It came from there, right? Problems that or etiology of it could be because of smoking, cigarette smoking, or exposure to carcinogens like dust, nickel, uranium, that kind of thing. So how would the lung cancer manifest? How would you be able to tell someone has lung cancer? Yeah, a non-productive cough, persistent cough that doesn't go away. Like, the person didn't have any cold or flu or anything like that, and they're just constantly coughing and never went away. What else? Yes, hemoptysis. Hemoptysis is also in tuberculosis, right? So yeah, hemoptysis. What is another one? So remember, when the person can't breathe well, what else can they do well? Eat well, right? Because you need oxygen to feel like you have energy in order to eat. So these people, they have a constant cough. They're not being able to breathe there. So they're not going to be able to eat well. So they're going to do what? Lose weight, right? So they're going to weight loss, anorexia. Okay. They might have fever too. They might have fever, wheezing, coughing, those things as well. Okay. So what would we do for them? Give them oxygen. Definitely want to give them oxygen. What else? Before we give them oxygen, what's Like, how do you know that it's cancerous, right? Biopsy. You want to make sure they understand, like, okay, this is the procedure we're going to do. This is why, and this is how it's done. So definitely want to do a biopsy. What else? Let's see. So let's say they have to do chemo or radiation. What's the difference?
Chemo's everywhere.
Yep. So it's a systemic, so it is everywhere. So what are some of the signs and symptoms that you would see that a person is on chemo? How would you know if they don't tell you? Losing your hair. So you're losing all the fast-growing cells, right? So hair, what else?
Sweat in their mouth.
Yeah, they have sores in their mouth.
Color of the skin.
They could lose weight. The skin could be a little off, too pale, right? They could definitely lose weight because they're not eating. Super fatigued, right? No energy. Muscle wasting. Nausea, right? Nausea would be one of them. So with anyone who's taking chemo, since we already know what is possibly going to happen, because it happens to everyone, we want to pre-medicate, right? We want to give them Zoloft or Reglan or whatever it is that's going to help them with whatever symptom is going to happen. So before you give them food, you want to give them Reglan to kind of subside the nausea, right? You want to do things ahead of time. You want to cluster care. You want to give them the oxygen. You want to do all those things. Okay, so let's say they're not, they're taking chemo. So chemo, like what are some of the things that you need to do as a nurse when a person is about to do chemotherapy? Okay, yeah. Mm-hmm.
You have to provide like ice pops or fluids or
Sure, sure. But mostly it's kind of like blood, right? You want to make sure that you are able to check them for the first 15 minutes. That's the most important thing because you want to see how they're doing for the first 15 minutes. Okay, similar to when you're giving blood. Blood, you have to cross, match, and you need 2 persons to check them off, 2 RNs or an LPN, that kind of thing. But that 15-minute is important, okay? Let's see what else. Pleural effusion might happen there too. I think that's our next one, right? Let's talk about pleural effusion. What is that about? Oh, wait, before we get from lungs. So let's say they are going through a surgery and they have to cut it out. They cut out a piece, cut out a lobe, cut out whatever, cut out a whole lung, right? What do we do as a nurse? How do we care for them? Okay, before the cutout, let's say it's a biopsy. Let's do the biopsy first. What do we tell them once they come? I'm trying to get you to think the same thing as catheterization. Like when you do, like what is the care that you have to tell the patient about a catheterization? Like you have to say they need to apply pressure, or it's already wrapped, or they have the ulnar thingy that puts pressure on them, right? So it's similar to biopsy for lungs. They have to put pressure on that area, right? And they usually lie on that area in order to apply pressure to that area, okay? So if there's a biopsy, but if it's cut out, are we going to have them lie on that area? No, it's the opposite, right? Because it's just a little piece when it's cut out, so you want to put pressure to stop bleeding. But when a lobe is out or a whole lung is out, if they lean on that area, the other lung will shift to it. And then you're going to have something called what? Tracheal deviation, which is deadly, right? So you want them, if they had surgery, you want them to lie on the good lung, okay? So that it doesn't move. So that's a key thing to remember as well. Okay, pleural effusion, where is the fluid? Pleural sac, right? We remember every organ has a little sac around it where it's allowed to take up space. And it has a little fluid so that when it does what it does, expand in however way, it has room to do it. But unfortunately, with pleural effusion, when there's fluid elsewhere that's too much, it likes to go into spaces, and that's a space. So you have fluid in the pleural cavity. So what do we do? You want to get it out, right? How much can you get out at one time? Yeah, 1,200. So between 1,200 and 1,500 is the max you can take out. Once you take out more than that, then you run the risk of the body feeling as if it was like hypervolemic shock. Okay? So, right. Let's see. What else? So we want to do a new thoracentesis here. What else? You also want to measure the fluid, see if it's acidic, if it's right. So pleural fluid is always pH less than 7.2. That's something to note. And you want to do a chest X-ray after you've done the thoracentesis. Why do you want to do a chest X-ray? Yeah, make sure that you got enough, or what level it's in right now, right? If it was here and it's all shady down here, so if I remove, it should be getting less and less each time. What's the other thing we can do with pleural effusion other than thoracentesis to get rid of the fluid? We could do diuretics. We sure could. What's another thing we could do that removes fluid from chest tube, and physiotherapy? Yeah. So physiotherapy is more when it's inside, because remember the problem with pleural effusion is that it's in the cavity. So it's not going to diffuse into any other space. You have to physically take it out. So things that physically take it out, like the chest tube and the thoracentesis, are the ones that are really going to resolve the problem. But if they have fluid, if it's pneumonia that's causing it, then that's going to help anyway, because it's going to get the fluid out from inside the lung area, which is eventually trickling down to the pleural space. Okay. So then we have postural drainage, right? When we think about postural drainage, we think of, let's see.
Yeah, we don't.
Oh, you don't? Oh, so I added that recently. I was looking through and I saw that I was missing that. So postural drainage, use of gravity to drain secretion. So that's kind of like just the shift of movement is causing the fluid to go from one place to the next, right? So proper positioning, lung segments to be drained is uppermost. So whichever lung that you want to drain, you're going to put it higher up. That's all it's saying. So that's a thing. Let's see. The other thing when we're referring to lungs is we want to see, and we have the chest PT there that helps with the postural drainage Miriam was talking about. What else? Inhalers. Let's talk about, since we're lungs, right? What should we know about inhalers and nebulizer treatments? What should we know?
Rinse your mouth.
Rinse your mouth, yeah. For why?
Yeah, the white one.
Thrush, yes. Yeah, you get the rush, right? So you want to rinse your mouth. How about a person who needs it and they're like, oh, I don't feel like I need it right now. Can they just not use it?
Depends.
Laura said, mistake. I love it. Yeah, it's not depend. They cannot. First of all, it's a corticosteroid, right? We don't want to abruptly stop any corticosteroid whatsoever, ever. But if we stop it and they need it, what is it not doing? Because that's the job of corticosteroids. It's not decreasing the inflammation. And so inflammation is not good. It's a necessary evil, right? We know when inflammation happens, white blood cells, red blood cells, platelets, everything comes in aggregates, but it damages the area. So we want to maintain it so that there's no inflammation, so the area is not damaged, okay? Let's see, what else can we say? Now, if a person does take, like, let's say, an inhaler, what are some symptoms that are natural that the inhaler can cause? Adverse effects, I should say. Yeah, it could cause tachycardia, anxiety, yep. Headaches, palpitations. Those are natural and normal. And I've seen it happen, and it's very frightening for them, but you have to tell them that's normal. It's part of an adverse effect. We don't like it, but if it's necessary, we might want to switch a different kind. Maybe that might be less strong, but it still does happen, and it's normal. Okay? So let's see, what else? Another thing is teaching, right? So which one do we take first again? Albuterol or corticosteroid? Albuterol, right? Because it vasodilates, right? It vasodilates. What else? It's a vasodilator. Tachycardia, we mentioned that. The other corticosteroids decrease inflammation, we mentioned that. It can cause oral superinfection, we mentioned that. Okay, and just to read through, can you remember a few of them? A few corticosteroid type treatments? We have, names of the drugs. Yep, we have Flovent, Advair. QVAR, yep. So try to remember a few that helps you distinguish, which one they're taking. Okay, let's move on. Okay, chest PT, what is that? Yeah. And why do we do it? To help what? Loosen secretion. It doesn't stop the secretion, but it loosens it. If it's too thick, if they're too weak, it helps bring it up. But what do we need to know about it? Like before we do it to them, what do we have to make sure about? They can. So what is one thing we can do to help them tolerate a little better? Because we are hitting them. Not analgesics, but no, just yes, put a piece of cloth, like whether it's a t-shirt, whatever, because we don't want to leave bruises, right, in trying to pat them. Or we can just have them wear the machine where it shakes them up for us and we don't have to do it physically, right? But if they feel pain, we have to stop, right? It's not, no, it's good for you, bear the pain, right? No. What else? So what are some contraindications? Why wouldn't you do physical therapy? Injury, yes. If they have a fracture of some sort, that's going to hurt. So we're not going to do it. That's a no-brainer. What if what?
What if they're on heparin? And you like do this, and you don't feel it, they don't feel the pain, and then the whole back is...
It bruised? Well, I don't have that here. But yeah, the cloth will help us not have direct contact, which will kind of lessen the opportunity for bruising. But you should never do it hard enough to cause any damage, any bruising, right? Let's see. I'm seeing if there's anything else I could add. So this was in relations to the postural drainage. So whether it's anything that you're aspirating, anything that you're collecting, you always want to measure, right? Anything in a chest tube, you want to mark where it is and how much it is. Because even though you want fluid out, remember we said we don't want it out too fast. So we always want to see how much we have. So that's something else too. Okay, so that was respiratory.